Okay, hello, good morning. Thanks for being here on a Saturday morning. My name is Joe Skitsky. I'm one of the surgeons here at Roswell. I focus on melanoma, and I want to thank Dr. Switzer for organizing this meeting. And I do realize that everyone here in the audience and online has been directly affected by melanoma or indirectly with family members. And so I'm going to talk about surgery, and I'm going to talk about my experience over the last 15 years of being a melanoma surgeon. And those 15 years have been a complete revolution. And so I'm going to share the good news with you about melanoma, and hopefully, everyone will see it. And so I have no disclosures. And just to reiterate, because you've already seen this and probably are well aware, melanoma is a cancer of the melanocytes. Dr. Prague went into good detail about how that develops and what that represents. And it usually starts superficially and it has what we call a radial growth phase. So it grows out and then it starts to grow vertically. And so that's why we talk about early detection. It's important to see that radial growth phase before it starts to grow vertically. And if you catch it early, the earlier the better, because melanoma can spread to other parts of the body. The lymph nodes is a very common area that we talk about, but other vital organs as well. And the risk really is based on the thickness. And so the thicker it is, the higher the risk is that it can spread, come back, and cause problems. And so that's why we talk about the early detection. And so the only way to, and again, two features that we talked about, and you've probably heard about it through most of the talks. The thickness is actually the most important feature. And if you look at it, this is like how it's kind of weighted. And if you look how thickness and ulceration are weighted, they outweigh all of the other factors, by several fold. And so these are the two most important features, thickness and ulceration. And so ulceration actually is a loss of the overlying epidermis. And that's probably for two reasons. When we know that melanomas have ulceration, we know they're more aggressive. And that's probably because they're just growing very quickly, outpacing the rest of the epidermis, but also most likely they're making factors that destroy the overlying epidermis. Those factors that destroy the epidermis are the same factors that allow the melanoma to get into the vessels, into lymphatics, and to spread. So if you have ulceration, that's why that's such a bad feature. That's why it represents a higher risk melanoma. And so the only way to actually figure out if a suspicious lesion is truly a melanoma is to do a biopsy or to get a piece of the tissue. And Dr. Andea presented the dermatopathology side of it, where we get the biopsy, it gets processed, they evaluate it. And the reality is that you can have a lesion that looks exactly like melanoma, and you won't know, you can't say it's melanoma until you actually see what it looks like under the microscope. A diagnosis really requires tissue, okay? And there's no way around that. And that's part of the role of surgery and dermatology, is that we grab tissue to figure out what the lesion actually is. And a good example of this is in pediatrics and adolescents. There's a lesion that looks exactly like melanoma on the surface when you look at it. And underneath, when you biopsy it and pathology looks at it, it's something called a Spitz nevus, which is completely benign. So really, you can have lesions that are suspicious and may not have the usual features of melanoma, and it takes a biopsy to figure it out. And so there's an old saying, it's kind of crude, but in medical oncology, there was a saying that no meet, no treat. Okay, so if you don't have a biopsy, you're not going to get any treatment because you don't know what it is until you actually see it under the microscope. Radiology has the same thing where they say radiation therapy has the same saying, which is no meat, no heat. And so you really need to see it and prove what it is. And so, as I mentioned, the thickness and ulceration are incredibly important because it leads to the staging. And the staging is really just these two features in terms of T staging. And so you can see that the T stage increases as the thickness increases. And if you have ulceration, that's a differentiation between A and B. And the survival difference is actually very different. If you have ulceration, your survival is actually going to be less. And so this is the two most important pieces of information that we need. And this, again, could be done with something called a punch biopsy. Some of you may have had punch biopsies in the past. This is where it takes a core of tissue. It's not a physical punch. and it grabs a core of the full thickness, and it gives you those two pieces of information that are very important, the thickness and if there's ulceration present. These are very well tolerated. It's just a little numbing medicine and then sometimes a stitch on the outside, but for the most part, it's very well tolerated. And then if you have a diagnosis of melanoma, typically you'll see me or dermatology, and what we talk about is a wide excision. That's the definitive treatment for all melanomas. And you want to make sure that you know the thickness and ulceration, because those features determine how wide around the melanoma you go. And so historically, and this is based from 1907, you would do 5-centimeter margins. That's a lot. That's like 2.5 inches all the way around. And so that was based on a single path report on an autopsy series where a patient had a melanoma and they had lesions that were 5 centimeters away from it. So they recommended 5-centimeter margins for everybody. And that sounds crazy, and that's 1907, but that actually went on until the 1980s or so. And so we went to 4-centimeter margins, and then in the 1990s, 2-centimeter margins. And I'm going to talk a little bit about that too. So it's become less and less morbid. And so you measure around the melanoma lesion and it creates a circle. You can remove a circle, but you can't really close it. It's kind of awkward. So you have to make it into this eyeball or football shape so that when it closes in a straight line. And as I mentioned, the thickness of the melanoma determines how wide around it you go. And we actually have very, very good data to suggest that anything that's more than 2 millimeters, we do 2-centimeter margins. Anything that's less, it's usually between 1 and 2-centimeter margins. And this is based on clinical trials that have gone on over 100 years. This is some of the best data that we have in all of medicine, some of the clinical trials that we've done for melanoma. And typically we talk about the cosmetics of this. You want to do 3 times the length to the 1 times the width. And if you do that, it closes in a nice straight line with very few, like we call dog ears or raised edges. And if you do it, less than 5% of patients will need a skin graft or anything like that. Most of these will close primarily. And so this is what it looks like when you excise it. You have this area that can close in a straight line, as I mentioned. There are some areas that you can't really close. If the skin is really tight, you're not going to bring it together. And this is something called healing by secondary intention. This is actually a very nice way to heal. This is, you saw some pictures of what we call acral lentiginous melanomas on the hands and feet. And sometimes on the palms and soles, you're not going to bring the skin together. And so you can actually allow it to heal. It fills in with what we call granulation tissue, and then the skin starts to grow in over the top. It's a very natural process. And so the skin that develops over top is very functional. It can callus. It's, most people don't even notice it. But the only problem with this is it takes time to heal. It is an investment of your time. Usually it's about 6 to 8 weeks for this to completely heal. But it is an option for certain patients. And so that's the definitive treatment for melanoma. And we still do that. That's standard of care, wide excision. And then the other role we have as a surgeon is to potentially further stage the patient with testing the lymph nodes. So we talked about T stage, and now we're going to talk about N stage, which are the lymph nodes. And this whole idea of the sentinel lymph node concept, this came about actually in 1995. And it was developed because in the past, if somebody had a high-risk melanoma, we knew that the melanoma typically would spread to the lymph nodes, and people tried to stay one step ahead of it. So if you had a high-risk melanoma on your forearm, they would think about removing all the lymph nodes underneath your armpit to try to stay one step ahead of it. The problem with that was that removing all the lymph nodes caused a lot of problems that I'm going to show you. Also, it was very nonspecific. There was really no clinical or overall survival benefit to doing that. And that's what we used to do up until 1995. And then 1995, Dr. Morton in California came up with this idea of the sentinel node. The sentinel node is like the sentinel soldier. It's a soldier that's out front and warns all the others, so that if you remove the one lymph node that is responsible for the drainage of the area of skin where the melanoma developed, And if there's no evidence of melanoma in this lymph node, you can pretty much say with 97% certainty that there's no other lymph nodes that are involved with melanoma. And so the Sentinel node test was really nice because you're only removing 1 or 2 lymph nodes, and you don't have to remove all the lymph nodes in that area of the body. And so this can be done by injecting the area where the melanoma was located with a radioactive tracer. That tracer gets taken into the draining lymph node. We can find that lymph node, and so we can do both of these at the same time, where we do a wide excision, and then we remove the sentinel lymph node at the same setting. That sentinel node, you have a handheld probe, you can actually find the radioactive signal, and then you can kind of zero in on it. And it's very nice because it can be a very small incision. You remove the node completely, and then pathology can look at that lymph node in good detail. So, for example, when we remove lymph nodes for colon cancer, sometimes we remove dozens and dozens of lymph nodes, and it's almost impossible to look at sections or slides of all of that because that would be tens of thousands of slides. So typically, in the past, we would just cut the lymph node in half and look at the surfaces. But with melanoma, and if you're only having 1 or 2 lymph nodes, they can section through the entire thing and look at the details of microstaging. So there could be microscopic deposits that you would not pick up if you just bivalve or cut the lymph node in half. And so this sentinel node biopsy or sentinel node staging has allowed for microstaging. So it actually has been very effective in further like kind of prognosticating or staging the patient. And so I'm going to go into what all of this means, but I'll share this too with you so that some of you may have had a sentinel node biopsy in this room. And what's interesting, and it's kind of reassuring, is that patients that come from Canada or across the border will have their sentinel node biopsy. They'll get injected with the radioactive tracer. And I actually feel much more confident in our borders because when they head back, they set off the alarms. And so the alarms can actually detect which isotope they have. And so they realize it's going to be, technetium, and they'll be like, okay, yeah, you had a sentinel node biopsy. Or if they had a PET scan, they'll say, oh yeah, it was this or that. And it's pretty amazing how sensitive it is. And so this radioactive tracer, it's relatively inert. It washes out of your body after about 2 days or so, but it is still detectable when you cross the border. And so this sentinel node biopsy, what does this mean? This is, again, a very large clinical trial. It was called the Multi-Center Selective Lymphadenectomy Trial. Roswell Park was a part of this trial in the late 90s, early 2000s. It had around 2,000 patients, and they were randomized. So they either had wide excision and sentinel node or wide excision alone, and then both groups were followed. And so the real, question was, is there a survival benefit? If we test the nodes and we find melanoma early, are you going to live longer because we can deal with it sooner and treat it sooner? The reality was that both groups did exactly the same. So that if you didn't have your lymph node tested, but you developed a lymph node later on down the road, the lymph node became enlarged and palpable, you can remove the nodes at that point and the patients would do exactly the same in terms of their overall survival. However, the sentinel node did give really good prognostic information. So for example, if your lymph node was negative on the sentinel node, we knew that you're going to do much better than your original staging. And so it's a really good prognostic test, but it really did not influence overall survival. This could change over time because this is before we started having the modern immunotherapies. And so there is potential that changing the stage could change the outcome in terms of what the patient receives afterwards. But so far, there's no definitive evidence that sentinel node biopsy changes overall survival. So what came next is MSLT2. It was the next iteration of this big clinical trial. And again, Roswell was a part of this in the mid-2000s. And we contributed a number of patients to this study. And, again, we talk about Buffalo being the city of good neighbors. Man, it's a city of good neighbors to the whole world. Some of the data that has come from MSLT1 and MSLT2 has influenced how melanoma is treated across the world and in a good way. And so what this study showed that if you had a positive sentinel node, the automatic reaction was to remove the rest of the nodes in the area. Was that necessary? So it split the groups into two, where if you had a positive sentinel node, you had your lymph nodes removed immediately versus just following it very closely. And if something developed, then dealing with it if it developed. And it showed very clearly that you do not need to remove all the lymph nodes immediately. And as a matter of fact, a good 80% of patients never go on to have their lymph nodes removed. One of the surgeries I used to do, and a lot of the surgeries I used to do, like lymph node dissections of the axilla, lymph node dissections of the groin, I hardly do them anymore. And that's awesome. So patients don't have to undergo these extensive surgeries. They don't have to undergo problems that can happen with these surgeries. If you remove all the lymph nodes underneath the armpit or the groin, you're at risk for lymphedema or swelling, and this is not insignificant. Some of these people are wheelchair bound because they're not able to walk. All the fluid, it's about extra 20 or 30 pounds of fluid. If this is your dominant arm, you're not going to be functioning very well. And so the fact that we've gotten away from a lot of the surgeries that we used to do is just a really good thing. And that kind of leads us to the idea of this era of de-escalation. So in the 15 years, the things that I used to do are completely different and a lot less, and definitely a lot less morbid for patients, and the outcomes are better, like way better. So for example, if I saw somebody when I started in 2009 and they had enlarged lymph nodes for melanoma, we did surgery and extensive surgery because that was the best option, that you had to get around it, and that was your best shot at getting rid of it. That, again, even with the best preventative treatments we had afterwards, probably about 75% of patients would eventually develop recurrence and die. So 25% survival rate back then. Those numbers now with modern immunotherapy, you remove the nodes, you gave immunotherapy, those numbers bumped up to about a good 50% of patients that were going to be alive. Now we're going to talk about this neoadjuvant, and Dr. Puzhinov, who's following, is going to talk in detail about it, but you can jump. The numbers are significant, up to 75% overall survival. And then in some groups with combination immunotherapy, the vast majority can have over 90% survival. So these numbers are just absolutely mind-boggling. And so the good thing is that we've been able to de-escalate surgery. So we're doing less and less, and the patients are doing better and better. For example, with melanoma in the past, we would do amputations, and then it became wide excisions with 5-centimeter margins, became 4, then 2. And actually right now we have a trial going on with one of my partners, Dr. O'Brien, who's looking at 2 centimeters versus 1 centimeter. So it's becoming less and less invasive. As I mentioned, we used to do elective lymph node dissections, and then sentinel node biopsy was developed. And now, in the past, when somebody had a positive sentinel node, we would do a lymph node dissection. That's obviously not necessary anymore, and we do nodal observation. So things have changed dramatically. And obviously, it's all because of immunotherapy. For the most part, we talk about the modern immunotherapies, and we talk about the historic use of adjuvant versus neoadjuvant. Adjuvant means that you get treatment after surgery to try to prevent the melanoma from coming back. Neoadjuvant means you get treatment while the melanoma is still intact. And I can tell you, as a surgeon, when somebody comes to me with a diagnosis of melanoma, they want to have the melanoma removed yesterday. They want to be out, done with it. That may, actually not be the best option at this point. And clearly you could win the battle, but you can lose the war. As I mentioned, those numbers where we talk about percentage of people that have good outcomes. If you have the same immunotherapy and you give it as an adjuvant, about a 50% chance that this melanoma is not going to come back or cause a problem. But in this group, in this large clinical trial, if you gave it as a neoadjuvant, you gave it while the melanoma was still intact, and you give a couple doses before surgery, the outcomes are dramatically different. It's the same medications, same everything. It's just that the tumor is intact and can actually act as almost like a vaccine, where it primes the immune response so that using the tumor in situ is to your advantage. And so being in a rush to remove the tumor may not always be the best option. And the nice thing about this neoadjuvant approach is that you can get treatment and then you remove the tumor, and that's what I've been doing surgically now. And you can gauge how good the response is. You could say that, oh yeah, like 2/3 of patients received we call a major pathologic response, where there's less than 10% viable tumor. Sorry. That's my timer. So I'm going to go right through this. So 2/3 of patients have a major pathologic response, and you can evaluate that tumor deposit, and it kind of dictates how treatment's going to go. So if you have a great response, you don't require anything else. No other surgeries, no other immunotherapy, no other adjuvant treatments. And again, this is the vast majority of patients at this point. Just to show you that this is now one of the surgeries that I do, and it's actually very minimal, where somebody has a tumor where they present with a melanoma. We put a little probe in the tumor. They get their immunotherapy, a couple doses, and then we can actually use that probe to find where the tumor deposit was, because sometimes the responses are so good, the tumor kind of just melts away. And so we can find it, and that's called the index node, and then we can evaluate it for a response. So the bottom line is that surgery has changed dramatically for melanomas. Melanomas used to be a disease strictly that was, surgery used to treat all stages. That has changed dramatically, so that surgery has become second, fiddle, I think, to medical oncology and some of the new immunotherapies. And it's, I think, fantastic for the patients. And that's all I have, and I can take questions at the end.